each patient stayed in the ER longer. They found that each patient also had more cost. There was a study done at the VA healthcare system. This just came out like a couple of years ago, I think, where in the VA, in the ER setting, they had NPs sort of practice independently without physician collaboration. In that particular study, at least, this care by nurse practitioners actually led to less favorable patient outcomes.
Look, unfortunately, in healthcare in this country, you always have to look at stuff from a financial perspective. There's less and less physician-run companies. Most of the time, they're becoming from nationalized staffing agencies or private equity. Well, doctors get short end of the stick because they're now viewed not for your technical skills, but are we considered on the balance sheet by these companies? Are we an expensive laborist?
A lot of my colleagues are using AI to generate notes. To me, that just sounds wonderful.
Technologies are coming, and whoever embraces it will survive well. If you're going against it, you're going to be left behind.
How is your current internal medicine practice different to how it was back when you were in training?
I think there's been a big emphasis, and I work with learners now, and I was a learner back then. But I think there's been a big emphasis on kind of protecting the residents a little bit. So making sure they're not overwhelmed, giving them time. So volumes are a lot less than when I was a resident.
Mm-hmm.
I remember each team would have, mid-20s patients. We would cap at 24, I think. And then now we have caps of, 12 to 16. Additionally, the EMR, when I did my training, like you said, everything was on paper. Now everything is on computers, and that's good or bad, but you have to learn how to use the computer system, which, once you do it, I think it is probably for the good. Just the complexity of the patients, I think, is a lot more now, just with the knowledge we have. I think that probably goes in hand with trying to have more reasonable volumes and things like that. I'll let you answer this a little bit, CNG.
Okay, sure. So I think the main thing, probably the disease processes maybe not changed too much from residency now, but I think the main thing being in the so-called private hospitalist world is that much more appreciation and respect than when you're in a resident for the allied health professionals and everyone that's behind the scenes that makes the healthcare machine work. Whether you're looking at how much work the social workers, case manager, how much pressure there's on them to meet the various institutional goals and agendas, from length of stay to patient turnover, how complex it is to discharge a patient and put a patient in there, cleaning a room, all the stuff behind the scenes. I think when you're a resident, you're just kind of busy in your own world. And once you become an attending, you really appreciate how much teamwork is required in healthcare, especially in the hospitals, like coordinating transfers, doing like all the stuff behind the scenes. The machine of healthcare is actually very interesting. I think that's what I have more appreciation than when I was in resident, is that how many people it takes to run a hospital smoothly. It's much more when you're a resident, because when you're in a residency, you're more focusing, what's the HGM rules? How much patients I'm capped at? I'm capped now. I'm doing this. I'm doing my research for my residency, for my fellowship, my program. When you're in a resident mode, you're just focused on education, the noon conferences, like all the appropriate educational stuff. Mm-hmm. And then when you get thrown in the deep end in the water of job life, then you see how much effort is actually really there to take care of the patients. And I think that's the main thing, is that the appreciation of the healthcare system.
Exactly. So yeah, I think you're right. And back to the paper medical record system that you mentioned, Dr. Iannetti. So I remember when we had paper charts, whatever, like 8-10 years ago, whenever that was the case, that when hospitals were being transitioned to EMRs, electronic medical records, and just so many physicians that were sort of on the brink of retiring, they retired because they didn't want to learn that new system. They're like, hey, screw this. Like they had practiced their entire life with paper records, and they didn't want to learn an electronic system and kind of all the technical details of it. So if they were kind of close to retiring, they just took early retirement, and they're like, I'm done with this. I don't want to learn a new tool. So I imagine kind of the future automation, future AI tools to be somewhat similar in 5 years, 10 years, whatever it is, when there is evolving technology, when us as physicians, we have to learn kind of a new way of doing something. I see a similar kind of pattern probably playing out, that, hey, you should learn this because this is going to result in these incremental benefits. And some physicians we're stuck to the old ways of, using our Epic, CERN, or whatever it is. And we wouldn't want to learn that new way of doing something. And the other thing that I'll comment to what Dr. Sohi was saying is what's totally different from being an attending physician compared to, let's say, a medical student, a resident, et cetera, is RVUs, especially in private practice. So as a resident or as a medical student, that's the last thing you care about, how many RVUs you generated. You just care about learning the proper technique of doing things, proper training, and so forth. But as a physician, especially in private practice and in the US, I would say more so than other countries, you're being tracked by how much value you're bringing to a hospital healthcare systems, whether you're consciously keeping track of it or not. Some healthcare administrator is that, hey, Dr. Sohi worked, 20 days in May and he earned these many RVUs. Dr. Bhagat earned these many days and he only earned these many RVUs, what's wrong, and so forth. So that is something that as an attending physician that you have to consciously kind of keep in the back of your head and not lose sight of that. So those are two things that at least come to my head when I'm thinking about how attending life is different than being a trainee. And being in academics, Dr. Iannetti, is that something you're keeping track of too or not so much?
They do.
Okay.
And it's more so from the sense that they want to make sure that you're seeing enough maybe to justify the presence of them having a position there.
Position, yeah.
But you don't necessarily need to, exceed like the 50th or 90th percentile or whatever for the RVUs. A lot of places I've seen do academic RVUs as well, where, you'll get so much credit for publishing something or giving lectures or having students and things along those lines. We're not quite that at where I'm at, but, they consider those things as well.
Right. And some centers have certain kind of incentive. Let's say you meet 8,000 RVUs or whatever it is. And if you do more than that, let's say if you meet 10,000, 15,000, whatever it is, essentially you're working extra, then you get incentivized with bonuses that, hey, you get whatever, $20,000 extra, whatever it is that you exceeded your RVUs and things like that.
There's all different kinds of models out there. There's no golden answer for this very touchy topic about how much appropriate reimbursement for your work, because every human feels like they do a lot of work and they deserve above market value for their production. It's a very normal human nature, right? So there's so many different models out there, right? So some companies are the RVU. Some people are how much you actually collect, literally how much has come to the company. Some hospitalist jobs are per shift, how much you are X amount of money for Y amount of patients. So I don't think there's a perfect system. But what it is that everyone kind of has to make their decision based on your geographic location, because every area is different. You can't compare Manhattan to Nebraska or Nebraska to Miami, Phoenix. Every area is different. Yeah. So as long as somebody's getting it to the appropriate market value, because there's a market value for everything, and no matter how good you are, you can't get 10 times what the market value is. You get 20% up and down maybe, but it's very interesting, a very touchy topic too, because we're here to help people, but everyone deserves their appropriate market value for the services rendered, especially in the teaching side, because a lot of stuff from the academic side is the same. Academic medicine also the same problem like primary care does, because they create so much value, which is not quantified by the system. For example, as a PCP, let's say you prevent a stroke. The only financial benefit is just that one visit you had. But if they had a stroke, the interventional neurologist would make so much money from taking out the clot, but the PCP would get nothing, right? So look at it from that side, from the financial perspective. Just like education, you can create an excellent physician, but a trainee, right? But how does the system value an academic teacher, or how do you value a PCP? But that's the tragedy of our system. For your side, how much an ablation is versus how much seeing one patient in the clinic is a big difference, right?
No, but I 100% agree with you. So unfortunately, the current system is not rewarding prevention.
Correct. Yeah.
It's better to prevent and prepare than to repent and repair. So being on the primary side of things, whether it's adult medicine or pediatrics or whatever, even psychiatry, prevention is not reimbursed or incentivized as well as it should. So exactly 100% right. If you prevented AFib, let's say atrial fibrillation, by weight loss, minimizing alcohol intake, whatever it is, that you just get to call it one clinic visit. But if you do an AFib ablation, then yes, hey, all the best, here's all this money or whatever the situation is. So that unfortunately is the current model, but hopefully that gets modified or adjusted in the future. But yeah, you're exactly right on that prevention is not being compensated or incentivized like it should.
Oh, but even interesting enough, as a percentage of the total cost, the doctors in general doesn't get as much as the public perceives. For example, for yourself, you might be putting in a pacemaker that's like $50,000 device, but what the doctor's fee to put it in is much less than the public would perceive for putting a life-saving device in something that you would do. The company will get a lot of money for getting the pacemaker, Boston Scientific or whatever company makes it, but your fee as electrophysiology would be much less than the public or other doctors would assume it actually is.
Exactly.
So it's kind of interesting.
Yep, you're right. So it's great for the industry if you're Medtronic,
Correct.
Boston, whatever you are. It's good for the hospital because they get to pay the hospital reimbursement kind of thing. And for the physician, you're getting a fraction of that. So, and same thing with any kind of procedure, whether you're doing colonoscopies, if you're doing, neurointerventions and so forth. Go ahead, Dr. Iannetti.
I was just going to say, one of the interesting things about hospital medicine is in the beginning of hospital medicine, our main value to the hospitals wasn't necessarily seeing patients. It was maybe moving them through the system faster, providing more efficient care, providing better care, better the metrics that you talked about earlier, maybe less hospital-acquired infections, maybe more evidence-based care. And I've sort of seen a shift a little bit back to, now they want hospitalists to be maybe a little bit more productive than previously, which again goes against the design of the hospitalist to really coordinate care, move patients through the system, and maybe a little bit less productivity focused and a little bit more quality focused.
Right. Are you guys seeing most internal medicine specialists as being hospitalists, or are they more so just internal medicine specialists and they do, let's say, 1 week in the hospital, 1 week in the clinic? Or are they just full-time employed by the hospital? What are you guys seeing kind of in the internal medicine realm currently?
Me personally, from what I see, looking at a lot of people, mostly people are, I'll be like a rare person that does both sides. I think everyone will be picking one thing. So if you talk to most people, either they're after training, they'll either do a subspecialty, endocrinology, ID, cardiology, whatever that is. But they would either be hospitalist or primary care. There'll be very few people that do more than one thing. Or if they do more than one thing, it'll be like they could be a hospitalist, but they have a side job as a rehab doctor, or they are affiliated with a hospice or something like that. But as you say, a main job, I think most internal medicine trained people either are a hospitalist or primary care. And many people, for various different reasons, do have more than one gig, so to speak, right? They'll have a main job, and then maybe on a weekend they work at a rehab, or before and after clinic, they'll do something else. But for all intents and purposes, I think 9 out of 10 internal medicine non-specialist doctors like us, you can say non-fellowship trained, they will be doing one job as their main job, and they may have something on the side, but there'll be very few people that do our PCPs and hospitalists these days. This is why hospitalists came up so much, because the PCP field became so comprehensive in clinic with all these authorizations and everything that the PCP can't really leave the office now in today's modern world.
Yeah. And as we think about like lifestyles now, I mean, it was hard, you'd round at 5 or 6 in the morning, see patients in the hospital, then you go to your office till 4 or 5, and then you come back to the hospital. And it just, as time's gone on, I think we care more about family life and things like that. So I think people, pick inpatient or outpatient. Now, the one thing I've seen in the past few years is subspecialists, sort of their model becoming more of the hospital week on. And neurology is a big example where now there's a lot of neurology hospitalists where they're just a week on or week off. And the week on, they're responding to stroke calls and things in the hospital. GI is another one I've seen that with, where, they're week on, week off, and the week on, they're just, doing scopes on hospitalized patients and hospitalized consults. And so I'd imagine because of the work-life balance, we might see that with some other, internal medicine subspecialties too.
Right. I've seen that as well. Like there's actually this, you brought up a very good point. So this might be, the market keeps reacting to the reimbursement and how people want to live their life, is that there's a new concept I've seen in several different specialties. Living in Phoenix, I can only comment on what I see around here. I've seen like job postings for, they're calling it new things like urology hospitalist, gastrology hospitalist, cardiac hospitalist. What that means is that the group, the doctors who are in the clinics and outpatients, they don't want to do hospital rounds. And instead of having the APP doing it, they'll have a doctor doing it. So actually it might be doubly beneficial that there might be reaction from the medical community that they don't want to lose all the consults to the advanced practitioner. So there's now actually a rise in hospitalist specialists, meaning that they don't do clinics. They're just there for all the consults. So that's kind of very interesting. So they might be one doctor. So all the other doctors, they can focus on their clinic and their outpatient surgical center. And one guy per week is just in the hospital doing all the consults. So no one has to worry about the hospital. That's very interesting reaction to the economy and the setup. Because the world is changing too. Because if you look at the Gen Z and other generations, and everyone is like want to work every single day, take the calls every single night. The work-life balance is definitely there, just like every other field. If you look at all this stuff in the media, everyone else is working 4 days a week, and only medical is left as 7 days a week job. Right?
Yeah, exactly.
So it's kind of interesting.
And I think regarding that, having, let's say, a cardiac hospitalist or something like that versus an APP, the the physician is going to get reimbursed higher than the APP would for, let's say, seeing those consults on the weekend or something like that. So that's probably partly driving that model as well.
Sure. And another thing will be, for example, yourself. So like, let's say that you had an APP associated with yourself around it, and you have some burden on your head thinking about a hospital. If you had your colleague in the hospital, you had no worry about what's happening on Saturday or Sunday. You could have off. So
Exactly.
that's probably another reason that, because even there's an APP, they're going to be associated with one of the doctors, and they'll still seeing the patients and all that kind of stuff. So it's a very interesting new trend, actually. I noticed the last few years.
Yeah,
and
that's interesting.
The last thing would be there's another reason for this, because of there's so much pressure in hospitals on the providers. For example, it doesn't matter you're like hospitals like us or specialists, everyone has their various metrics. Patient satisfaction, HCAHPS, all these kind of external factors that no doctor likes to talk about too much, is that if you're in a clinic, you can't improve your patient satisfaction, the various metrics, answering all the nurses' issues. So having the physical presence in the hospital 24 hours a day is kind of what's required now in modern medicine. Yeah.
What would you guys say has been the most memorable moment of your career so far, since medical school, let's say residency, attending physician? What has been the most memorable part, whether it's good or bad? What would you say, Dr. Iannetti?
Working on the academic side, I've had a chance to be involved with some academic organizations, the American College of Physicians, or ACP, and being affiliated with them. I had a chance to give a lecture at a regional conference that I went to as a medical student. And then now I get to do it as an attending with a lot of the mentors that I had, giving it to them. And it went over really well. So that's something that jumps out to me. Again, just seeing several of the learners that I've had and had a chance to mentor and just see where they're at now. That always gives me great satisfaction, especially when they reach out to me and tell me how well they're doing, or you get to see how well they're doing. So definitely that. There is a joy to the clinical side and just seeing patients that, maybe you had someone really sick in the hospital, and then maybe you'll see them out in the community several months later and seeing how well they're doing, and they remember you and thank you for the care you've given.
What about you, Dr. Sohi?
I think it's always hard to identify like one particular moment. For me, generally, I was fortunate enough that doing both sides of the like inpatient and outpatient. Most joyful part is that when you're seeing somebody very sick in the hospital, and then you're fortunate enough that you get to see them in the clinic too sometimes. So when you get to see the recovery, they're in one situation in the hospital, it might be in the ICU on pressors, being treated for sepsis, intubated, all those types of critical situations, and then they're going to come in a few weeks and see you in the clinic, and they're back to their normal self, going to the grocery store after the visit. So you get to see humanity in all its different aspects. I think that's what most joyful part is, that we get to see people in their toughest situations when they're in the hospital, and then try to prevent that situation when they're in the clinic.
Yeah, I think all those kind of small moments add up and they make you grateful. Being a proceduralist, it's always rewarding when you put a pacemaker, for example, in a patient that has complete heart block, that came in with lightheadedness, passing out, extreme fatigue, or so forth. And after the pacemaker, they feel like their normal selves, and you see prompt results. I think being a proceduralist and in the cardiology world, so those are some of the things that I find rewarding, and patients being grateful, and you see them in the office and they're now, look like normal people instead of being debilitated and very sick initially. And so I think those kind of things really add up and make you more grateful when you're helping people in different facets of healthcare. What would you say to medical students who are thinking about going into internal medicine or inpatient medicine, Dr. Iannetti?
So I definitely think you have to do what you like first and foremost. Because if you hate your job, then it doesn't matter how much money you make or anything like that. So you have to like the subject matter. You have to like being diagnosing diseases and sort of that classic detective you'll hear, figuring out what's going wrong. And so that would be my first thing for internal medicine. If you want to do surgery, you have to like the OR. You have to love the OR to where, you don't mind being there 10, 12 hours a day. But first and foremost, do what you like. After you find that, you do want to consider some of the financial aspects, how much money you'll make. You probably want to consider, where you want to practice, what you want your day to look like. And then ultimately, I think the best thing about internal medicine, what drove me to internal medicine, is provides so much different variety for what you can do. And you can always reinvent yourself. You can do inpatient medicine the first part of your career, then you can do outpatient. You can always subspecialize. And so there are so many different pathways or avenues you can choose. So if you don't know what you want to do, I think internal medicine is probably a good avenue to take.
What about you, Dr. Sohi?
So I think it's a very rewarding field. As you mentioned, it's the most important thing is to find out what you're truly passionate about and trying to go for that field, because any financial motivation, that's always secondary. It's always about finding what you truly like. What's your internal motivation? Whether you're specializing or you're going to general internal medicine, the thing that drives you from the inside. But all the other stuff will always fall into place, like your job setup, financial things. But following what's really inside of you, that's the single most important thing. Because as you know, working in medical field, the person that focuses on the financial aspect will be the most disappointed, because the time, energy, effort is definitely not financially rewarding when you look at literally how many hours, time, energy spent. So this is why you really have to focus on what's your internal motivation, what's your guiding force. They say pilot light, North Star, whatever that thing's inside of you, follow that.
And I would also add to what both of you have said that in internal medicine, the ideal kind of personality would be someone who's very team oriented, that you get along with other people, because you have to be a good communicator, because you're communicating and getting along with and working along with nurses, social workers, administrators, consultants, other hospitalists, and so forth. So I think it's crucial to being a good internist that you have to be a good team player. You have to communicate well, communicate promptly, and so forth. And if you're a medical student and you feel like that you don't have that camaraderie, or you're not a good team player, then, and you just want to sit in a room all day by yourself, then consider radiology or pathology or something else like that.
I couldn't agree more. I really couldn't, because so much of what we do is communicating to specialists or social workers, or above and beyond the patients too. But we're kind of the captain of the team, to say, and we're trying to get everyone on the same page, even if we're not entirely coming up with the game plan. We're trying to execute it.
Exactly.
So we really are like kind of like the point guard in basketball. See, the point guard in basketball, they have to bring it up, pass it to their team. If they don't pass it, the team is not happy. So that's how kind of the analogy of primary care and hospitalists is. You have to be kind of like more like I like to use the analogy of the point guard in basketball, because the point guard brings the ball up. They're the one that's setting the plays, but they're not the one that does a slam dunk. It's going to be the center, the power forwards. You'll not only get to be flexible, but you have to be sometimes differential. You may be doing a lot of the setup work, but the final intervention may be the stent that the cardiologist is going to place or things like that. So you have to be you can say like a good team player and a good setup man, and always be flexible, because there's so many different things coming at you, whether it's medical, the system. So I just think it's a very dynamic field.
Exactly. And yeah, you're exactly the quarterback or the point guard or the main kind of person that's in charge of that patient that's admitted to the hospital. The cardiologist is going to put a stent and go away the next day. The GI person's going to do his colonoscopy and go away the next day. But they're kind of the main person in charge of that patient, advocating for the patient and, addressing 20 different things that's wrong with this patient. I think that you should be comfortable being in, those shoes, and you should be comfortable communicating well and being an advocate for the patient. So I think for medical students, that would be the key message, that having those attributes will probably lead to a promising internal medicine career.
Correct. But there's also one caveat, because I'm also a very fair person, and we understand everyone's life is very different. For example, it's an important topic about career choice selection. For example, I'm also like a product of like you could say IMG's International Medical Graduate. What is the one actually positive of people who are trained outside of America is that they usually have much less student loans than people trained in America. So if you're like a young person, a 30-year-old, 32-year-old, having $300,000, $400,000 in debt, and then you look at how much income you're going to make, a lot of people will naturally, why would I want to pick a job where my yearly salary is going to be less than my student loan is? Like, you have to understand there's a lot of financial pressures on people too, and their perception of what is beneficial for them. So I think this is another tragedy in this country, is that the student loans for every type of job, not only doctors, nurses, teachers, anything after high school is overpriced basically now these days. Like, the burden that the young people have for student loan is actually also driving some of the physician staffing problems. Because let's say if you're a 30-year-old and you're $400,000 in loan, you're not going to probably want to become a primary care or hospitalist. Yeah. You'll naturally want to become interventional cardiologist, something. These unfortunate drivers. Then also another negative thing is that in our field, is that people look at their job prospects. There's a lot of interesting choices that have to make from the financial perspective. But of course, it's always the nice things that we say about following your North Star and all that kind of stuff. But people do have to make decisions that fit their reality. But I think this is one of the tragedies about this current world that we're in, is the burden that young people have now. Even before they're getting married, starting families, buying their house, they're already in so much debt.
Yeah, exactly. And the per student,
Yeah.
college student debt amount, medical student debt amount, the cost is only increasing, let's say
Correct.
10 years ago versus compared to now. And the amount of students that are also interested in pursuing medicine, that's also increasing. So yeah, unfortunately, that is the state we're in now. If you guys could change one thing about hospital medicine, how it's being practiced at present, what would you change, Dr. Iannetti?
I think a lot of places have maybe gone to like a rigid 7 on, 7 off schedule where, the providers are in-house 12 hours a day. And that's a really good schedule, I think, for, maybe when you're young and don't have a family and weekends don't matter as much. I think I think if a lot of places would maybe look at scheduling models, that didn't maybe have that 12 hours a day, just because I think to work 12 hours a day sometimes can be challenging and lead to burnout. So I think maybe being aware of that. And if some people like that model, keeping it, but having flexible models for people. And then I think the other thing is just to be aware of the administrative challenges for a hospitalist. I think that's why we're there, to deal with a lot of those things. But I always hope people that are managing hospitalist groups just understand that there's only so many hours of the day. So in the end, you need to consider productivity and those metrics, but just to be aware that in order to fully do those metrics, maybe having less patients, to help providers meet those metrics and accomplish those metrics.
I think if I had a choice to make one change in the hospital system, it would be that if there was some way, it sounds like in a fantasy world, but if the actual healthcare workers, whether it's nurses, case managers, doctors, would probably have not a better say, but at least some of their viewpoints or opinions should be more implemented in the agenda of institutions. I think that's what drives burnout. As a lot of people are switching jobs or taking a step back from nurses, doctors, is because they probably feel that their internal goals and values are not represented by the organization. For example, being a hospitalist, the pressures in any hospital is to get the patients out of the hospital, to do this, do that. But these are not the metrics that doctors or nurses signed up for. There's no medical student that went to school and said, how can I reduce the length of stay for the hospital, right? The thing is, a lot of people are driven in a negative way by external forces. So I think there needs to be more, maybe with the new generation coming up, Gen Z is more a collaborative mindset, that there needs to be more engagement of healthcare workers in the metrics and viewpoints of organizations. Of course, there's the financial reality. I understand that. There's no problem with the companies. They have to make their bottom line. But I think what happens, the number one key thing if you look at the body language of nurses and doctors, the number one thing that's driving negative opinions and negative mindsets is that they feel that their own internal voices, their goals, what they think is right, is not being implemented by institutions across the system, not just one hospital, just in general. I just feel that people feel that they're just implementing the policies of insurances in hospitals these days. This is unfortunate.
And it is a challenging environment for hospitals too, because, they're getting paid less by insurance companies. It is always to do more with less, to try and save money across the system. And so you can't necessarily fault them. But so maybe that would be my change. You mentioned the big, beautiful bill earlier, but there'll be less money going to Medicaid, and rural hospitals will suffer.
Yeah.
So, a more streamlined investment in healthcare and things along those lines.
Yeah. And the way I kind of see this playing out, let's say in the next 5-10 years or so, is small rural centers, hospitals, ambulatory surgical centers, etc. I see them either shutting down or being engulfed by bigger healthcare centers. Or hospitals merging, so they have one larger entity rather than two smaller hospitals. Something along those lines. And this goes back to kind of the big, beautiful bill and just where I see the healthcare system headed. The other thing is probably AI and automation is going to continue to get integrated into the healthcare system. So whether we're using AI more in the ER setting as triage and see who's more critical and sending us alerts and so forth, or in documentation, that AI will sort of be engulfed into the EMR system that particular healthcare system is using. And documentation, hopefully for us, becomes easier and things are more streamlined in that setting. And the other thing I also see likely happening is more inpatient procedures. Now, this is coming as a proceduralist. More inpatient procedures will be shifted towards the outpatient setting, so ambulatory surgical centers. We're already seeing this with, orthopedic procedures, let's say pacemakers in certain states, but this will definitely continue to evolve, and even ablations in the near future will be taking place in ambulatory surgical centers, and the hospital itself will likely be reserved for more critical procedures. If someone's having some kind of neurosurgery or someone comes in with a heart attack, ST elevation MI, something along those lines. So that's how I'm kind of imagining things being shifted because of the current practices or the current trends. What are you guys suspecting how things will evolve, let's say, in the next couple of years? Do you guys see similar kind of changes, or do you guys see something else panning out?
I mean, you talk about independent hospitals or smaller hospitals being engulfed by bigger centers. In West Virginia, that's happened. There really aren't very many independent center or hospitals left. And so I certainly think nationwide, you get better negotiating power with insurance companies whenever you merge together. You can purchase your supplies maybe at a cheaper rate. So I definitely think that's coming. It's already happened, but it'll be happening to an even higher degree.
Exactly. So let's say if you're Kaiser, you have more of a negotiating power, more of purchasing power compared to, let's say, if you're a small rural hospital in Alabama. I think financially that will definitely pan out. What do you think, Dr. Sohi?
I think so. Yeah. So I think we're going from this current issue you're talking about, the rural hospital. I definitely think the long-term trend is that smaller independents, either they just be engulfed or they become just a referral center for the bigger hospital. So you go to the big city because the robots, the technology are way too expensive for the smaller hospitals to afford. But I think one of the key aspects that might have to come up will come up naturally or because of the one big beautiful bill or other cuts in the system is that the increasing complexity and advancement in like personal wearable technologies. For example, let's say you as a cardiologist, as an EP clinic, if a young patient has an Apple Watch or other wearable technology at home, why do they need to come to the clinic anymore, right? So the app will manage if you have RVR, they took the extra beta blocker at home. In the past, they had to go to the ER for that to get that recommendation. Now, maybe the app that's on the iWatch will just say, just take another Metropol at home, you're good. Take it easy. So the wearable technologies, because if in theory, we don't know, I'm not an expert on things, but let's say the one big beautiful bill, all the cuts go through, everyone has to adjust to take care of the same patients with less money. So what's that? The only way to do that is increasing AI use, increasing outpatient wearable technology use. And you're right. So hospitals will be more and more reserved for sicker and sicker patients and more things in outpatient surgical centers. I think we already see the trends all across the country like that. But I just think this wearable technology and apps and all this kind of stuff will come more and more. I think we had some introduction in the COVID era, like lots of stuff went tele that time. And now there's so many companies. Let's say a lot of like mental health companies or you could say lifestyle medication companies. They're all telehealth companies and they're very successful entities. So that's going to transition for other types of healthcare too. Because if you look at it, the generation that's coming up, we're kind of part of that. Everyone is loyal to apps, not certain providers. So maybe somebody will come up with more PCP apps plus the apps. Like the young people are coming up, Gen Z. They're not going to wait. Like let's say you're going to a doctor's office now, right? So you see a doctor, you do a blood work in 3 weeks, you see them for a follow-up. This generation that's coming up now, they want to be seen right now, get a blood work now, and the results now. So that can only be done with apps, right? So
exactly.
So the way the world's changing is going to change so fast.
Well, hospital at home, in some larger urban areas where you have a nurse that maybe comes to your house, draws some blood, you monitor the patient at home, and you stay at home, and the nurse comes and gives you your medicine. So I don't know how much that'll take off, but certainly with technology, more and more feasible.
Yeah, exactly. And you have, definitely smartwatches, and they're very capable, and they're going to continue to evolve. You have smart rings that can give you so many health metrics, your health rates, your sleeping habits, all that kind of stuff. And that'll only continue to evolve further. And, we have those glucometers that tell you how your blood sugars are doing and what spikes your blood sugars and all these kind of things. And all that data is going to get input into some online platform, and you can keep real-time tabs on how things are looking, either from the heart standpoint, your glucose standpoints, whatever. So that's very interesting. And
Sorry. The other important trend I see in coming up personally by just looking at behaviors and probably just anticipated reactions is that a lot of the younger doctors will continue to hyper-specialize. Like they're not going to become general cardiologists. They may become some super EP or some super interventionalist. And then what happens is at the generalist level like us, there's going to be even more with AI, more with advanced practitioners. The people will probably not want to do as much as what we do actually because everyone looks at all the different variables. So I think doctors are going to become hyper-specialized going in the future. And the generalist category will be even more open than before. So whoever's busy now is going to be even busier in the future. And then the AI will leverage people to do more work. So that's going to bring up another controversy. If these insurance companies see that AI is doing all the progress notes, discharge summaries and everything, maybe they have to see more patients for the same amount of money. Because
the reimbursement's going to go down.
Yeah. So they're going to say, oh, your pre-rounding time is done by AI. Your progress notes are done by AI. All you have to do is examine and see a patient. So that means you can see 10 more patients a day. So you never know how these technologies, other people will react. But there's definitely some positives and negatives of everything.
But you're exactly right about the super specialization. So let's say even in cardiology, you have, cardiologists, and you have your electrophysiologists, you have your interventional, you have your heart failure specialist, you have your preventative cardiology. That's also a field now. And taking this into the other specialists, like in GI, you have your regular GI person, but you also have your hepatobiliary specialists that are involved in liver transplants and things like that. I think that'll continue to evolve further, and you'll have specialists that are becoming more and more niche into one small particular category. And that's expected as we're learning more about certain diseases and treatment options. You cannot just be regular cardiologist and be a specialist in electrophysiology, heart failure, and everything, for example. So yes, that'll definitely continue to happen. I 100% agree with you there. Yeah, but you're right. So how does that affect primary care? How does that affect internal medicine? How does that affect general internal medicine? So that is the question.
Yeah. So I think,
how does that affect care in these rural areas where there's maybe not enough of a population to have these specialists? So people are going to have to travel more, travel further. And you may have people that have limited transportation means. So all these things will have to be considered. But then technology may help. Maybe you can do a lot of the visits rural and things, but telemedicine, but certainly for procedures, it's going to be a lot of travel time, unfortunately, I think, for some patients.
Correct. So that's why it brings up that controversial word that doctors don't like, is that the word provider is going to be used everywhere now. So it's not going to be, oh, this is the PA, this is the DO, this is the MD, this is the MP, this is the DNP. It's going to be, oh, you saw the provider today, and then people are happy they were seen by somebody. So a lot of people's ego is going to get hit because everyone's going to be kind of considered equal. But that's kind of the reality that we're going into. And the doctors, you have to accept that the world is changing so fast, and we definitely have to adjust, because there's with the way that I think the problem with healthcare is that the more patients you see, the more administrative stuff that comes up. So whether let's say you're a PCP, if you start seeing more and more patients, then you have to review more and more labs, do more and more FMLA, prior authorization. Then there's only X amount of work you could do safely. So you're also limited by being a human. You're not a robot. So this is where AI is going to come through. You can imagine if AI can start doing people's FMLA, looking at prior authorizations, reviewing labs, that maybe your doctor's time will be leveraged. But that's probably the only solution we have, is leveraging the humans that want to work with AI. But there's definitely, I don't think there's any way to stop the advanced practitioner trend. And also there's coming up with more and more roles. And when we were training, there was no such thing as CRNA from my recollection. And now they're dominating the anesthesia field. I even read about another field coming up, a certified RT. So it's going to be like kind of like an ICU doctor, like how they're going to upgrade RT into a kind of like a CRNA kind of thing. So the world keeps changing because there's more work than there are people who want to do the work. Because of our doctor system, the residencies, until like when I was doing residency applications not that long ago, but the residency spots were fixed. But now every community hospital almost has a residency. That's hospitals that 5 years ago never anticipated to have a residency. There's so many residency spots. So the supply is also increasing at the same time. So maybe it'll catch up. Who knows?
And I think that kind of fits with the growing aging population. Now you have more and more people that are getting older, older than 65. And these people are living with chronic health conditions that may have killed them earlier back in 20 years ago. So now, but everyone's living till 70, 80, etc. And they have diabetes, heart disease, cancers that were killing them earlier, but now we have better technology, better treatment. So now people are living with cancers longer. So we have an aging, chronically ill population that we have to tend to. And so we definitely need more physicians and more providers, including APPs. So hopefully that helps us with kind of the physician shortage that we're expecting. One more question I have for you guys. What is the most either positive or negative, up to you guys, patient interaction that you can remember in the last, let's say, 5 years or so? And what did you learn from that experience? What would you say, Dr. Iannetti?
Well, I remember that there was a patient I had, and she was really sick and she was young and she had some neurological disorder, but all the complications from it. And so I remember, in at the time I was working a week on or week off. And so she was in the hospital for months. So I was pretty much seeing her every week I was working and really dealing with her husband a lot, who was really advocating for her and doing a good job of advocating for her. And so I got to know him really well. And then I forget, she finally got discharged, and I happened to run into him probably like 6 months later, out in the community. And he said hi, and then I asked how his wife was doing, and unfortunately she passed away. And so hearing that, obviously I was sad, sad I didn't know. But he was very thankful for the care we provided and the communication I had with him. And, that's just something that sticks out to me, because in the end, she had a bad outcome. She had a bad disease, but he was just kind of happy I spent the extra time to talk with them and explain things and interact with them and understood that he was advocating for her. In a sense, it was sad to hear that his wife had died, but it was rewarding to hear that he appreciated her care despite the fact she'd passed away.
Yeah. That's always, I think that comes to, in any specialty, when you lose a patient for whatever reason, I think communicating with their loved ones, their family members is always crucial. What about you, Dr. Sohi?
I think probably the most rewarding case I've seen in all these years of work is probably closer to when I started working. Is that one of my first few days or weeks of being a hospitalist, I saw a young patient just like around 33 or so. He actually had a STEMI and a stent placed and all that kind of stuff in the hospital, being his hospitalist. Then I got to follow him up in the clinic, and then because you're kind of almost around the same age, and such a big event happened to him. So maybe we connected on that kind of level, kind of same age. And then you see the disease process in the hospital, following him in the clinic. That really touched me, like the importance of preventative healthcare, preventing something from happening, things like that. So I just think that just seeing both aspects aside, so there's so many different cases you can identify, but I think that's probably one of the more touching or something that I can remember for the rest of my life. Yeah.
For me, I would say I had this 70-year-old lady that I was seeing in the office, and she had a defibrillator system. I saw her in the office maybe 6 months ago or so, and she was coming in complaining of multiple episodes of lightheadedness and a couple episodes of passing out too, actually. So when I saw her in my EP clinic, we interrogated her defibrillator system, and I discovered she's had multiple episodes of ventricular tachycardia, which, as you know, it's a deadly heart rhythm and can often be lethal. So when we discovered her multiple episodes of ventricular tachycardia, we admitted her to the hospital for further evaluation. She ended up actually going a VT ablation by me, and we did the VT ablation case. And as you know, this is sort of a higher risk procedure. It's a very technical procedure, and fortunately, we had good results. We mapped the VT, so we're finding cells that are misfiring from within the heart that are causing this deadly heart rhythm to occur for her. And essentially, it's kind of like finding a short circuit in a complex electrical system within the heart. And we found where her misfiring cells were. And with the ablation catheter, we gave electrical energy to quiet down or sort of kill the circuit that's causing the misfiring. And once we accomplished that, the patient did good. And in the EP lab, we had a big sort of sense of relief at that time that things went well. We were no longer able to induce her ventricular tachycardia, and we were happy with the results. And seeing her the following day, just seeing follow-up procedure patient, and she's looked much better, and she was sitting there having a conversation and laughing with her loved ones, and I just remember that going into the room, it was like a sunny day, and she was there having a conversation. She looked much more lively, she looked happy, and I remember that, and I just felt very grateful that I had the opportunity to help her in that aspect and really improve her quality of life. And since then, I've seen her in the office a couple of times, and she's continued to do well from that standpoint. No more VT and no more passing out episodes. And so that's one patient that sort of sticks out more recently that I was very grateful for, that I had the opportunity to help her in that setting and make a meaningful impact with what I had to offer. So we'll do the rapid fire. First question. Favorite comfort food after a long work shift? Dr. Iannetti.
Chicken wings, like hot wings.
Dr. Sohi.
Home cooked meal, that's it.
Favorite medical app or medical gadget or website? Dr. Iannetti.
Up to date.
Up to date. Dr. Sohi.
We'll go to AI, Claude, and
ChatGPT. Yeah, I would say I use ChatGPT quite frequently too, but for the app, I would probably say MD Calc. Helps me calculate their risk scores and all that kind of stuff. Favorite medical TV show? House, Scrubs, or Grey's Anatomy? Dr. Sohi.
Scrubs.
Dr. Iannetti.
Scrubs.
Yeah, I would say for me, it's close between house or scrubs, but I'm leaning towards scrubs just because it's funnier. One piece of advice you wish you had received as a trainee, Dr. Iannetti.
Wow, that's a harder one. I would say be open to change because there's always going to be change. So just be ready.
Dr. Sohi?
It's going to be harder than you think, but you'll enjoy it more than you'll think.
Huh, interesting. It's going to be harder than you think. You'll enjoy it more than you think. That's a good one. That's a good one. If you were not a physician, what would you be doing today, Dr. Iannetti?
Maybe some sort of science professor, like a chemistry professor.
Okay, Dr. Sohi?
Okay, looking at all the stuff going on now, I'll try to do something in AI.
So be a software developer or something like that?
Something in AI, yeah.
Yeah. I think for me, it would probably be something in finance. I don't know exactly what, but something finance related. Or maybe real estate too. I enjoy both. Perfect. Awesome. It was pleasure having both of you here, and we had really meaningful discussion.